MMS Medical, and I leave Kate take over from here.
Hi everybody, so I am hosting this webinar today in partnership with MMS Medical, so thank you to everybody at MMS. And this is supported through the lifespan, supported standing through the lifespan, and we are Ultimate Medical, the manufacturers of the EasyStand and Zing product ranges. We will be covering supported standing options from early intervention through to elderly. And the clue was in the title that supported standing through the lifespan is actually a massive topic. So I'm afraid I've had to take out all the studies and all the evidence, but I will be pointing you in the direction of where you can find all of that information. I'm going to have to go through many of these slides quite speedily to cover everything that we need to cover today. But if there's anything you want me to go over, there's a Q&A box that you can enter questions in. I'll try and answer them when they come up, and if not, I'll answer them at the end. And also, if you want to cover any topic in more depth, if you contact the MMS team, we can organise another webinar or send you information to do with the topic that you are interested in. So without delay, I'm going to get started. So the course objectives: who might use a standing frame, why use a standing frame, how to use the built-in adjustments to best accommodate your client, and a product range overview. So who should stand? Anybody essentially that's using a wheelchair will need to be standing on a regular basis, because once we are seated for long periods of time, and this goes for office workers as well as so able-bodied office workers, we need to be standing regularly. And some of the populations that we work with: people with cerebral palsy, spinal cord injury, multiple sclerosis, traumatic brain injury, and spina bifida and muscular dystrophy. Just 1 second, I've got to let somebody into the room. Okay. And standing, benefits of standing. So there's lots and lots of benefits of standing, and I think everybody that's on this call today will be aware of these standing benefits, and this is why you're on this webinar, is because you believe in standing and why we should be standing. And one of the things I would like to highlight is future technology and medical advances. So if there are any advances in the future with medicine, operations, or future technology, the people that are in the best health or have been maintaining their muscle mass, bone mineral density, they are going to be the most likely candidates for this future technology and medicine. And so that's one element that I just wanted to highlight amongst all the others that we're all well aware of, to keep in mind some of the motivations for standing. Because sometimes when it's really, really long term as well, it's very hard to become motivated to stand. But the idea that there might be something that might allow somebody to walk in the future or to regain function is very, very motivating. If you would like to see any information about research on the medical benefits of standing, you can click on these links, which I will send in the chat at the end, sorry. And you can search for the research studies based on whether it's spinal cord injury or scoliosis or contracture management. You can search via a condition or a problem, and then you can get all the relevant supporting documentation if you needed to, for example, defend why you are prescribing a standing device for one of your clients. And to review all of the evidence on, if I go back to that link, sorry, the second link, research and articles, brings you immediately to two really important documents, which are the reviews of evidence done by Leslie Glickman and Ginny Paleg and Paula Geigel. They have reviewed all of the studies and all of the evidence, and they have given it a rating of how strong it is, and then the suggested dosage, so how much standing you should be doing, and then the populations that have been in these studies. So you can see for pediatric standing, there's one document, and then further down, there's one for supported standing in the adult population. Sorry, I'm just going to mute.
On by MMS here.
So I'm just muting the people that are coming in. Okay. So again, if there's anything there that you want further coverage on, please just send an email or contact your Richard at MMS or your contact at MMS Medical. So the EasyStand product range, we have, sorry, I'm just meeting another person. We have the Zing Portable, which is really early intervention. So we can accommodate somebody 45 centimeters tall. So it's really, really tiny. So you're looking at your 10-month-old or somebody with really developmental delays that are really, really petite. So the Zing Portable is a supine, prone and upright standing frame that is also folding, so you can move it around with you. And it's really, really teeny tiny and it's really suitable to the early intervention stage. It also has 15 degrees of bilateral leg abduction. Then we move on to the Zing MPS, which is multi-position standing frame, and it takes you from supine to upright and directly into prone without removing the child. So you can really play between the different supine and prone positions, without taking the child out, without having to flip pads or remove anything or take anything off and take the child out. So it really gives you a lot of flexibility, particularly therapeutically, because you can test or play with a little bit of prone in 5 degrees and then bring them back without having to take the child out and stop the standing session. So the Zing starts at around 50 centimeters. Hello to the new people. If you could just mute yourselves when you come in. Welcome, welcome. I'm just going to, if you can't mute yourselves, I'm just going to mute you. Okay. So Zing MPS, supine to prone in one motion, and it also has 30 degrees of bilateral leg abduction, so 60 degrees total. And it has we have loads of options to accommodate all different types of bodies. And then we have the Bantam range, which goes from 71 centimeters up to 1 meter 68. And you can actually kind of go a little bit above that, depending on body proportions. And that is a sit to stand device with the supine option. Then the sit to stand range, which it accommodates both kids and adults, to be honest, because you have some really tall teenagers and you have some smaller adults. So this is the strap stand, the first one that you can see, and it's like a traditional style standing frame where you wheel your wheelchair up to the standing device, a strap goes underneath your bottom, and then you pump yourself up or somebody pumps you up into the standing position. What is really nice about this is, although it's a very simple standing frame, it has multi-adjustable foot plates, so you have plantar flexion, dorsiflexion, and a slight bit of rotation, and the knee pads are multi-adjustable, and the arms that pull you up into standing actually have 2 bends which pull you up in an arc rather than a straight line, and that reduces the pressure on the knees as you're coming up into standing. So I always view this as quite a simple standing frame, but it can do quite a bit, and it's really great for heavier users as well. It has a capacity of 159 kilograms, and the height range as well is quite flexible. So it's a good all-rounder, but it doesn't offer the higher levels of support for example, you know, a tetraplegic patient or somebody with like high levels of spasticity. You're going to be moving to some of the other products we have in our range. We have mobile options, which you can add to the Bantam that I mentioned previously, or the the Evolve here, which is manual self-propulsion wheels that you add to the standing frame and that they can then push themselves around. This is not a device that you're going to be taking down to the shops. It is for moving around in your kitchen, and it is really for people with really good upper body strength. active wheelchair users, for example, would be good candidates for this, but it's not for everybody because you do need a good level of upper body strength. Great option for some people though. Then we have the Evolve, which is our, if any of you have worked with EasyStand in the past, this is probably the product that you will have come across or have seen. It's been around for a very long time. And it starts at 1 meter 22, so it can be used in the pediatric branch, and then it goes up to 2 meters 11. And so I talk about you can use this for children, but I have actually had to use one of the XTs with a teenager, the most rapidly growing teenager I've ever met. We assessed with the Bantam medium, we delivered it, and then I kind of panicked, thinking I'd done some really poor measurements because he was growing really, really quickly. We adjusted it. So all of our products have inbuilt growth adjustment without tools. It's really easy to do. So if you do get yourself into a position where you may have done measuring incorrectly, I didn't on this occasion, you have got some wiggle room to play with. You're not stuck with what you've ordered. You've got growth adjustment pretty much all over the devices that's inbuilt, and it's tool free. So it gives you that confidence to be able to accommodate and adjust. And in this case, with this rapidly growing teenager, sorry, we managed to adjust it fine, but then we had to go to the Evolve Large, and then we had to go to an XT within, I think, a period of 4 years. So that's an extreme case, and I've never come across that again. But we do have some teenagers that may require the Evolve XT, which goes up to 2 meters 11 and has a really high weight capacity of 159 kilograms as well. And then we have the glider, which is a sit to stand device, and your arms move your legs. This is amazing for all of our wheelchair users, even our really active wheelchair users. They will be sitting in wheelchairs. They might be doing basketball or wheelchair tennis. They might be very active, but it's always in a seated position. Even these recumbent bikes or motormeds or TheraTrainers, whichever one you use, they're seated. So this allows you to stand up, fully upright position, and then your arms move your legs, so you get that full body workout. Then so into the, sorry, we're into the Zing, so just to show you quickly some of the features, which is it's foldable, it's adjustable, and it has abduction. And there's just some very cute images of it in use and it folded. And then we have the Zing MPS, which is, come back in. Zing MPS, which goes from supine to prone in one motion. So you can see in the image, I hope that you can see anyway, that the child is being moved from a supine position into prone. So where we've used this is with children that wouldn't typically be using a prone device. We would pop them in and allow them to do 5-10 minutes, maybe even 3 minutes of prone, to work on extension, to work on upper body control and head control, and then just move them back to give them a rest. It really gives a lot of flexibility. And then we have abduction. So it's at the pivot point of the fulcrum of the hip. And so you get a real true leg abduction. You don't get pulling, especially at the knee and the foot. Sometimes you can see a bit of pulling. It's coming directly from the hip so that you really get a true abduction. It's really comfortable for them. There's a little angle indicator at the back of each leg as well. So you often want to grade it because sometimes going straight into 60 degrees is a bit severe and a bit uncomfortable. So you can grade it. So go to 15. And either in that one session, you can leave them there and then bring them out a little bit further, or over a period of time, try and increase that degree of abduction. In terms of abduction, this is a whole topic in itself. I could speak for an hour on hip migration and the development of the acetabulum and why standing and using abduction in standing is interesting, particularly in the early stages, so in early intervention stages. But that is a whole topic in itself. So if you want any information on CPUP, which is the Swedish program in Sweden where they've reduced hip dislocations almost, not entirely, but almost, and they've reduced spasticity and pain through a very, very long program, and it's being implemented now in other places. So we have CPIP in the UK, but if you want any information on their light system, their red, amber, green light system, or their app, please get in touch with MMS Medical and we can give you more information on that. This is the case study of Briella. So Briella has spastic diplegia, and she had intervention from 18 months, and she had a walking frame, but in America they tend to either have a walking frame or a standing device. You don't tend to get the both. And I know in the UK that can be the case. I'm not sure in Ireland, but often you either have one or the other. And basically, her story follows that she started to progressively show a migration of her hip, and that they were basically getting to the point where they were going to have to do an osteotomy, or and I'm not going to try and pronounce this because I've tried to pronounce it several times, but basically it's an operation where you're trying to align the growth with pins, and it's obviously quite invasive, and the mother, Caroline, basically looked for other options, and she came across a physiotherapist who suggested a standing frame with abduction. And so Briella stood with her standing frame and her hip migration reduced, so she didn't have to have the operation. And she's now got improvements in her posture, her upper body strength, increase in her bowel function, and her lower extremity range of motion has also improved since using the standing frame. So it's a case that I like to highlight this one because we know children that can't walk should be in a standing frame, but sometimes children that do walk should also be in a standing frame to get that alignment, because especially if we've got a gait pattern that's not it's not symmetrical, it's not aligned, we're going to have growth on one plate more than the other, and then we're going to start to get more asymmetries as we grow. This was Christian in Denmark. He had they weren't sure what his condition was, but he sat in a frog leg position and he needed a lot of strapping. He had a tendency to play and undo headrests, and they tried loads of standing frames and they hadn't had any success. So we tried the Zing, and it was the Zing knee supports that really maintained his legs in the position. So placing the knee pad on the patella actually created that alignment and stopped him from being able to move his legs, rotate them, and pull them. He was pulling them out of other devices. He tolerated this for 40 minutes. He didn't play with the headrest, so he was comfortable, he was happy, and he was more responsive in the Zing. He was smiling and playing. Lola, so this is one of the benefits of the supine to prone in one motion. We were setting this one up for Lola. She had knee contractures, pelvic obliquity, her left foot was in plantar flexion. She was quite complex, and we popped her in, and as I was chatting to the physio, we were sort of going through my bag of bits of what we could use, different foot straps, and one of the carers in the background just started pressing the button. And so she went from upright and she was going into prone, and I said, no, stop. And as we came up to her, the physio went, wow, look, and her quads were engaging. You could see her little muscles engaging, and that was something that they were unaware of that she could do. And so that small degree of prone, she can't stay there. She couldn't stay in that position for a long time, but a small degree activated muscles that she wasn't activating normally. So they integrated it then into her program, that she would do a bit of prone standing and then come back for rest. And then we had a little bit of abduction, not too much, because it enabled her to have better head control. So just a slight bit of abduction increased her head control. So then those are the supine prone standing frames, which I'm sure most of you will be really, really familiar with. Most children have a prone, supine or upright standing frame. Sit to stand though is less common, particularly in with children. I think it's less common. So just going to go briefly over why we will use sit to stand. So for function, massive one here. When we have the tray that follows us from sit to stand and we can maintain forward a forward gaze, we're not looking up at the ceiling, we can be more functional. With the tray as well, in a good position, it allows our arms to work and move, and we can look at what the task that we're doing. We're not back looking towards the corner of the ceiling. What it also means is that you can do more standing if you are functional, because if you can do something and not break that task, so with sit to stand, you can sit back down again and stand up, sit back down, so you don't have to break your standing pattern, your standing routine, in order to carry on a functional activity. Inclusion, contracture management. So sit to stand, we have a vertical shin when we're going from sit to stand. So that means that we can actually stop anywhere, really. So even if we have quite a severe contracture of the hip knee and we don't have a lot of range of motion, we can still stand and try and improve range of motion, which goes on to the second point. We can try and achieve a gradual stretch over time. Upright standing, so we've touched on it with function. We want, as much as possible, if we can build blocks and have the hips above the knees, shoulders above the hips, and head balancing on top of the shoulders, we get all the weight going through the long bones and through the feet. So in terms of stretch, range of motion, that's beneficial. And the peer-to-peer eye line, looking forward, and then allows you to kind of balance neck and head control and work on head control. And then this is an example of, generally speaking, when somebody's got hip knee contractures, I tend to go for a sit to stand over a supine stander. So this is our Zing here on the left, but you can see that with the vertical shin, it's going to be more comfortable. And you can achieve, then you can try and see if you can stretch over time with the sit to stand. You can do those minimal increases, and I think it works really, really well. Range of motion, so it looks like she's the second picture isn't the best one, but she's happy. I believe me. The first session in the EasyStand, she had limited range of motion in the hips and in the knees, and after prolonged use, she could get into a fully upright position. I like this one because on the right hand side, it says someone said no to standing today, so we're just sitting, and I think that's really, really good, because sometimes we don't want to stand, and I think we should allow that flexibility, because next time we can just say, okay, we'll just sit in it, and then maybe next time you might want to stand. So it's making it comfortable and flexible. Integration and autonomy, we use in the UK, we use the EasyStand in some regions. They are in mainstream schools with provision for children with disabilities, so that they're in their history lesson, and you walk past the class and you can kind of see some heads standing up in the whatever lesson that they're in. And obviously we use them a lot in special schools, so that you can basically take part in your lesson and do your standing program. And also then physio or OT sessions can focus on other elements, not just standing. We have Leo here who had spina bifida. He refused to go in a standing frame, and we had to kind of bribe him with a lot of Lego playing and bubbles to get him in the first place. But once he got in, he actually really enjoyed being able to go from sitting to standing. And I actually checked up with the mom a few weeks ago to see if he was still using it, because, you know, with peer pressure and a new device, people are compliant. And so a year later, I wanted to check if he was still using it, and he's still using it, and he's got better range of motion in his hip, and his hyperlordosis has improved as well. I work with a lot of children with Duchenne's muscular dystrophy, and they are often anxious about new equipment. So all these stories, when I talk about people with DMD, they don't want to try anything new. And the general consensus is, I find this more comfortable than my wheelchair. Can I stay in it? They tolerate it really well, and they find it very comfortable. So Amanpreet had one at school and one at home. Abby had a severe hyperlordosis, so we had to use the combination of sit to stand and supine to give her some relief of her hyperlordosis, and to help basically give a lot of flexibility with positioning. And she was really conscious of her peers and how she came across, and she didn't want to go in a supine stander because she felt self-conscious, whereas this felt more acceptable to her. And we had to work on her foot positioning and alignment. This was a really funny story. So we went to a school in London, and the mat evaluation had shown that she had hip knee contractures of 50 degrees. So we popped her in, and basically she ended up going fully upright into an upright. There were no fixed contractures, so it was behavioural, and something about being on the mat, and then I think being in the device, that she was fully supported, and it was going in a natural progression from sit to stand, and it was consistent on both legs. And she probably didn't even realise what was happening until she was almost in the fully upright position. So it's always really interesting to just see, if they have got fixed contractures, what they can achieve with the sit to stand. And this young lady, she was in a really, her one leg was crossed right the way over to the other. She had a subluxated hip, so it to really carefully grab onto that hip and like pull the leg out, put the knee pads on really quickly, get that alignment, and get her up into standing. So she doesn't have a perfect position here, but compared to her seated position, it was amazing. And there's like a really positive response into this one. A little bit of fun now, so you don't have to listen to my voice, or, well, you still have to listen to my voice, sorry, but you don't have to look at me. This is the mobile option in action. So you've got the Bantam there and the Evolve with the mobile option. The little girl had a spinal cord injury, and that's a physiotherapist that's able-bodied there. And she genuinely was upset that she lost. And then this is where my attempt to be a comedian always comes in. I start making jokes about like the dog and the horse, and I'll save you from that today. And this gentleman here, his wife reported that from following use of the EasyStand mobile. So this guy's obviously incredible. I mean, I've even seen a video of him getting himself into the back of his van with the Evolve mobile. It's quite impressive. But he had 75% recovery of bowel and bladder function. He's regained movement and sensation through using the EasyStand and other therapies as well. He's got movement confirmed by the GP. He's transitioning to walking therapy, and the next step is reassessment to see whether he can have a lower level diagnosis of his spinal cord injury. So EasyStand. EasyStand design, it's got biomechanically correct pivot points. So when we do our adjustments, we line up the hip pivot point to the pivot point on the unit. There are there is one big exclusion or time we can't do that. It's with a severe kyphosis. So we do have to make adjustments to that. But generally speaking, we align up those pivot points to the pivot points on the body. And then what you get is really nice alignment. It's really comfortable, and you get a real good stretch on the hip flexors because you're getting that fully upright position. It's a modular system, so you can add and remove supports where necessary. You get a gradual ascent from seated up into standing. You can stop at any point, so you can do your physiotherapist stand fully upright, or you can have a more relaxed stand. It doesn't have to be all or nothing, and you can take it each day differently as well. You know, this day I can only do 10 minutes of standing, but maybe next, and I have to sit a lot more often, but maybe tomorrow I can do a bit more. Transfer options, we have lots of transfer options. I'm going to show you videos rather than talk about them. But often people look at the devices and think, oh, how can you get into them? So I'll show you some of those, because actions speak louder than words, I think. They're safe and robust. They're easy to recycle. We have lots of them being recycled in many countries in Europe. And they're adjustable without tools and inbuilt growth, which I've already spoken about. So the Bantam has sit to stand with the optional supine, and just show you that in action. Knee blocks, I highlighted this because for me it's a real fundamental part of getting really good positioning, and that's both in a supine standing frame and but particularly the sit to stand. So we place the patella as much as possible centrally in the knee pad and on the patella itself. What that does is that gives you really good alignment. So the knee pads are doing the lion's share of the pelvic alignment, keeping the femurs in line. It's keeping the pelvis back and stopping posterior pelvic tilt. And you can also correct abduction and adduction. So if somebody's internally rotating, we can correct that with the knee blocks by the positioning of them. They're also nice and soft and comfortable. And if I was in person with you, I'd be making you all get in there. Just because I think it's hard to sometimes envisage, like to know, but once you get in, you can feel that it's very comfortable. The shadow tray, for me, it's really, really important because it follows you from sitting to standing. This means many things. It means it can keep you back. So rather than relying a lot on harnesses that pull maybe from the shoulders, you're actually pushing back at the sternum or lower down. For some spinal cord injured patients, they need a lot of pressure at the stomach to help regulate orthostatic hypertension or blood pressure. So by really pressing that pad into the stomach, it can help with blood pressure. And then some people might need it higher up if they have less function, to give them more support. So the tray and the pad attached to the tray gives a lot of support in the anterior plane. And then on top of that, you've got function, so you can rest your arms on it, you can do tasks, and you don't have to break whatever activity it is because you want to sit down. You can continue doing play or work in sitting or in standing. So you've got a lot of adjustability. You can raise the tray height, you can change the angle, you can change the depth. We have a lot of adjustability with foot plates. So the Bantam in particular has a lot of adjustability. So we can do toe in, toe out, plantar flexion, and remove the foot plates and bring them forward and backwards, and change the width as well. Supine I've already mentioned. Evolve, sit to stand. And here are some of the transfer options. So we've got independent seat to seat transfers. So there's a lot of space, and it's just the seat height is just slightly higher than a wheelchair height. So there is upward trajectory when you're going in, but luckily when you're coming out, it's downwards. We have an open frame so that people can come in, assistants can come in and help with the transfer. And then with mobile hoists, we have different options depending on the mobile hoist. Sometimes you have to come in around the back, as you can see on the image here. Often you're putting one leg around the front of the frame and through the arch of the back legs. Sometimes you have to come from a more forward angle. Unfortunately, you have to kind of figure that out with each mobile hoist. They're all a little bit different. And then I'm just going to show you a very able transfer. Just going to interrupt him here. If he had the shadow tray on his version, he wouldn't need to use his head on the headrest. It would be supporting him and giving him freedom, so he wouldn't have to hold back, and he wouldn't have to use his head to support himself because the tray would be coming into his chest. But I like this because he decided to make this video. He thought it was beneficial. It's really real, and I really like it. And then we have high level tetraplegic. I'll let her tell her story. Sorry to cut her off there, but I just think she looks so great in that picture. She does a lot of talks now. She does around America. She does talks about living with spinal cord injury, and but I love that picture of her. I think she looks great. Just a couple of notes from a product perspective. So you can see here she's got a cushion in between her knees. That's because she's got like a one-piece knee pad, but the independent knee pads that we provide would give her the correction that she needed without the cushion. And also the tray that she's using is a standard tray. The shadow tray would again be optimal because it follows you up from standing, so it gives you that support, especially somebody with such a high level injury. Okay, because this was standing through the lifespan, and I basically had to like pull a lot of stuff out to fit it into 60 minutes. Some of the things sort of seem to randomly appear, but this is a customer story who had not stood for 14 years, got multiple sclerosis, and very sensitive to position changes. It took almost 3 weeks to tolerate standing fully because he had problems with dizziness and hypertension, but built up endurance to be able to stand 30 minutes 3 times a week. Again, I'm not actually sure if it's on, I'll have to check on the EasyStand website to see if it's there, but there have been a few more studies from the UK on multiple sclerosis, so I can send those to MMS to share them with you as well, from Loughborough University. Standing with tetraplegia, so often we kind of resort to going to a tilt table with somebody so complex, and particularly post injury, it is important to just gradually take them up. But for home life, it's the Evolve works really, really well. And here are all really high level tetraplegic clients using the EasyStand. Eddie, C2, C3 complete spinal cord injured patient, and he's in the glider. So you can see here, he's been held by the physio at his head. You could have a headrest here. He's got tourniquet hand gloves on, and his hands have been attached with the Velcro straps on the tourniquet gloves to the handles. And then the other physio is moving his arms backwards and forwards. So traditionally at this glider, you kind of associate it with lower level spinal cord injury patients that can, actively move their arms. I argue there's almost more of an argument for higher level tetraplegic patients to use a glider, because at least an active wheelchair user is shifting their weight in their wheelchair. They've got more activity, whereas this really gives you a full body movement, arms, legs, whilst in the standing position. So he when standing, passively moving in the glider, there have been many occasions where Eddie has either felt weight bearing in his feet or the initiation of muscles trying to help engage whilst gliding. And I'm reminding you, this is a complete spinal cord injury. Since using the glider, he has increased range of motion and decreased spasticity and tone. Some nice images of different people using the glider. And this is Joanna, who's T12, complete spinal cord injured patient client. She can accomplish new movements like knee extension and to feeling new sensations like tingling in her quadriceps and calves. She's also been able to feel sweat on her knees, which is below her level of injury. And she quoted, "I can feel tingling in my toes." So which device for which item? I can actually open up questions here as well, because in my fear of running over, I've really sped through everything. So if we want to go back over into some more detail, please raise it in the question and answers. I'll just start talking about which device for which type of complaint. So early intervention, the Zing goes really tiny and does the leg abduction. So you can start working on, particularly for GMFCS levels 4 and 5 in cerebral palsy, start working on trying to improve or trying to prevent hip migration. Vulnerable hips, the Zing, so I've already referred to that. Hip knee contractures, for me, the sit to stand, bantam and evolve. Behavioural issues, again, for me, it's the bantam and the evolve, because we find a lot more compliance, particularly as they get older and they can start refusing to go into standing frames. Independent transfer, my first choice would be the evolve, because it is slightly lower seat to floor height and it's got kind of a more open frame. However, we do successfully do it with the bantam as well. Spina bifida, both bantam and evolve. Hyperlordosis can be really tricky, but both the sit to stands with something like a universal belt, which has a lot of support but elasticity and is comfortable, and you pull round in the stomach area, or the opposing part of the lordosis, so where we have we're pushing back with the belt and with the tray, to try and alleviate some of that pressure. And then severe foot deformities, so the bantam, and probably with supine as well. So again, if you've got really, you know, if you've got valgus or something really kind of where you can't put full pressure on the foot plates, then you might be looking at adding the supine element of the bantam so that you're not putting full pressure on those feet. So we have 10 minutes to go, so I can totally go back now to some of the items that we've covered in this session. Does anybody have any questions? There's a Q&A box that you can type a question into here. I can show you the website where I can show you all the, if I go on to the part of, I can show you where you can go and find all the studies, depending on the type of condition somebody might have or complaint. So if I go to here, can you see the screen? Can you see the website up on the screen now, or is it still on my presentation? Sorry, can somebody tell me?
Still on your presentation, Kate.
Still on the presentation, thank you. Okay, let me share my screen then. Okay, can you see that now?
Yeah, that's good, Kate.
Yep, great, thank you. Okay, so when you go onto the EasyStand.com website, you've got, this is EasyStand, you've got YStand, and then you can go to the medical benefits of standing. There you can look at, for example, let's go to strengthen cardiovascular system and build endurance. And then you can either click all research, which will just give you a list of all the different, oh, that didn't work. Sorry. Let's pick effects of immobilization, and then it will give you the studies for risk of immobilization. You can get all your information there. There's also case examples, and then you can, if you go on the research and articles section, you first have the systematic review of pediatric supported standing programs. So this is where it shows you how much standing to do and for what condition. And then the same for the adults here, the systematic review and clinical recommendations for dosage of supported home-based standing programs for adults with stroke, SCI, and other neuro conditions. Just to stop sharing now. Okay. Yeah, so sorry, in my anxiety to fit into the time, because I do talk a lot, you see, and I do ad lib, so I've really tried to restrain myself, and I've done it too well. So we have 10 minutes remaining. If you've got any questions, please ask. I have got loads of pages of studies as well to support what I've been speaking about today, whether it's range of motion, bone mineral density. Bone mineral density is probably the most contentious of all the reasons why to stand, but we have contraction management, spasticity, bowel and bladder, circulation. If you have any questions, I can quickly find a slide to cover one of those topics. And if there's anything that you want to go over in more detail, like I said, if you contact MMS Medical, we'll happily put together a specific content on that topic. So no questions. Oh, hello.
I think you may have answered everything, Kate.
Just wondering how. Oh, I've got a question. Yeah, we've got a question. Oh dear. Now I'm showing how technologically rubbish I am. How adjustable is the seat? Does it allow for modular seating? So no, you could theoretically add a modular seat, but what I would say is the pivot points on the unit are really good. So you don't want to add another layer of foam, because then what's going to happen is you're going to raise your pivot point. You're going to raise the hips above the pivot point, and then you're going to start to get bad alignment when you're going from sitting to standing. Another thing is the pelvis is different when you go from sitting to standing. So in the seated position, the pelvis looks different to the standing position. If you mold them in the seated position, when you go up to standing, what it's going to kind of do is it's going to push you forwards into a strange kind of duck-like position. It's going to kind of fix the pelvis. So generally speaking, I haven't often found the need to add a modular seating system or like something in there. We have hip guides, we have multi-adjustable foot plates, and you can adjust the knee pads. If you've got a specific person in mind, maybe if you do you want to give a bit of detail, maybe, and then I can maybe address that. But generally speaking, we did go through a period of trying to put aftermarket backs on, but again, it just messes with the pivot points. So we try and stick with the basic sort of back and seat, and use the hip guides, belts, and pelvic supports to manage the other elements of the postural support. Super, thanks. I might have also missed, but does the EasyStand allow for adjustments in hip abduction? So the Zing does. The Zing the supine prone standing frame Zing has true hip pivot abduction. The EasyStand sit to stand products don't. You can, on the Bantam medium, move the foot plates out into a more outwardly position, and you can move the knees into a more outwardly position, which would provide a little bit of abduction, but it's not a true hip pivot abduction. It's more of a kind of a mod that can be done that's not the true function of the device. So generally speaking, if you need abduction, it's the Zing or a standing frame with abduction, and then sit to stand, straight up, straight down, as much as possible. But we do allow for a little bit of width, particularly on the Bantam medium, which goes from 70 centimeters to 1.68 meters. Good to know that. Thank you. And thanks, Sarah, for asking me a question. And then if you have any, because sometimes it's really hard to just kind of see what can be achieved. If you have somebody that you want to do standing with, if you grab one of the team from MMS, they can bring you, I'm giving them work to do. They can bring you a bunch of products, and then you can see which one's going to suit based. As long as you give them the height and the weight of the person that you want to look at, they can bring you a couple of products and then decide. Because sometimes, for example, I get called in to use the strap stand, and I always bring the Evolve with me, because the strap stand, it's so simple. People, it's transfer free essentially. So you kind of go, oh, great, we'll pop them in and pop them up, but it doesn't always work. So I like to have the Evolve there as a, just in case that one doesn't work. So we've got another option. So that's always something that you can look into. Great. First time in history that I've finished on time. So thank you, everyone.
We're very impressed, Kate. Thank you. Thank you so much for joining us today, and to everybody for logging on. We do really appreciate it. As I say, there's a number of the team available for any inquiries or queries. There's